da na gani ina shi na fara yin na sai guda biyu. It's shi ne mai sake gani wani an ce bai da kalas da apple.
Good evening, all. Good evening, our facilitator. So, welcome to another session in our series of first contact physiotherapy series workshops. So, I think it's already time. Our YouTube live streaming is working, and also I'm still admitting people. I think also our host is available, so we can start our meeting. Thank you, ma'am.
Hello everyone. I think we should just give some other people like 5 minutes since you said you're still admitting others in, so we don't start and they kind of join in. Do you get this? Like 5 minutes. So in the next 4 minutes, let's say we'll start proper. What do you say?
Okay, ma'am.
Thank
Okay,
you.
ma'am. Okay, ma'am. You're welcome, ma'am.
Servants, how did Jehovah protect him? What prayer did he pray so that Jehovah would protect him? And how did he protect him? What did he provide for them? Okay, let's answer the first question. What did you Elisha pray for? Good. It's like so what did you run after? Like God did on the mountain. Yes, Angel is carrying as I can see in the picture. This is how you see through. That's why Elisha said that they are more with us than them. You see them all around. Leave her. Precious. If you feel her, stop. So this assures us that the right always be done.
I think we can start now. It seems everyone is ready, right?
Okay, ma'am. Thank you, ma'am.
Let me just share my screen here right here. Oh, I'm always forgetting to see. Can you see my screen?
Yes, ma, we can see.
Okay, good. Just let me put it on the presentation mode, and then we'll start. Again, I'm having a bit of issue here, sorry. So I just want to just go into the hide view. I don't know. Good. So let's just start, I think I'm good. Good evening, everyone. Hello, can you hear me? Oh, yes.
Yes, we can.
Good. Good evening, everyone, and welcome to another session. Today, we are going to be looking into mechanical versus inflammatory pain. There is stratification and imaging decision, like in an advanced clinical reasoning for the low back pain generally. So our plan for today will be looking into mechanical low back pain, recognizing the pattern, non-specific disc-related radicular presentation. And we'll also be looking into spondyloarthropathy. We'll be looking into differentiating the inflammatory back pain and other axial spondyloarthropathy clues. And we're also going to be looking into risk stratification, how we can match the patient to the right level of support they need. And we're also going to be looking into imaging, like when to request for imaging, and when we're requesting for imaging, what is it that we are looking for, and if anything will change if we do the imaging. And then by the end of the day, we're going to be having a kind of discussion. So it's not going to be only me talking. So yeah, that's how the day will go, hopefully for us. So the first thing we'll be looking into is mechanical low back pain. So it's a kind of refresher for us because obviously I know all of us here see patients with low back pain, loads of low back pain. But yeah, I just feel we should kind of refresh a bit. Mechanical low back pain, as we all know, is a pain that is arising from the muscles, from the joint, from the disc ligament, and other biomechanical structures in the lumbar spine. And it is usually influenced by movement, by posture, or even loading pattern. And it can occur without any features of serious inflammatory, serious spinal pathology or inflammatory pathology. When we're looking into mechanical low back pain, we look into like the typical pattern. Obviously, it's load or posture sensitive, and it may vary with activity. So activity can exacerbate it. Some activities can exacerbate it, and then rest can ease the symptom. And it's often improved with movement or change in the posture. Another thing is we're not expecting any red flag or like neurological progression in mechanical low back pain. So obviously, when we see patients with back pain, we've got to screen for any serious pathology, which was our topic last month. And we've also got to identify any radicular features and then consider inflammatory back pain as well. And then we stratify this patient as early as possible so we are able to manage them best. So for the FCP mindset, we shouldn't like label every low back pain as mechanical low back pain until the pattern is really. Can you hear me? It's a kind of all right, everything is fine. So we've got to look into neurological status and the red flag that have been all this need to be actively screened. There is a background noise coming. Is it from my own end? I don't think it's from my end here. It's like someone is unmuted and then the background noise is somehow distracting, please. Yeah. Again, we look into the three most common presentation of low back pain. The first one is non-specific, like we've discussed, without any clear identifiable structural causes, and it is admin, can you mute everyone and then so that there will be less distraction, please? Yeah, so yeah, thank you, thank you, admin. So like I said, it's often influenced by posture, the activity, the level of stress and other biopsychosocial factors. And then the other pattern of presentation is when it has to do with the disc-related pathology. So here we are expecting pain that is associated with disc degenerative changes, the bald. Okay, let me carry on. Balding or herniation, and it may also remain localized or it may also remain localized or sometimes irritate or compress a nerve root. And then the the third presentation is the radicular pattern when nerve root, I don't know, the noise keep distracting me for some reason. I'm sorry. Can everyone mute, please? So, with the radicular pattern, when a lumbar nerve root is irritated or compressed, there'll be like leg dominant pain, paresthesia, weakness, or other reflex changes which might occur. And yeah, this in time bring us to the sciatica. So when we say sciatica, what are we describing? So we're describing pain that is radiating into the leg, which is caused by inflammation.
Igbe. That far side.
Let's say
Then you did down.
I would just kind of
No.
admin.
So please,
Admin. Okay. So when we're talking about sciatica, then what are we describing? We're talking about pain that is radiating into the leg that is caused by inflammation or compression of the lumbosacral nerve root, which is which is the L4 to S1, and it is pain that is felt in the back or sometimes in the buttock and radiates below the knee into the foot or the toe, and in a sciatic nerve distribution, obviously following the L4 to S1 pattern. And it's also a radicular pain, like also known as radicular pain or lumbar radiculopathy or sometimes lumbosacral radicular syndrome. So it's commonly associated with some symptoms which include tingling, as we all know tingling or numbness, like neuropathic pain quality, and loss of muscle strength, dermatomal or sensory symptoms, and sometimes myotomal weakness or reflex changes may also, all this may be suggestive of radiculopathy. But then with sciatica, in about 13 to 40%, or like about 30 to 40% of individuals will present with sciatica at a point in time, which will settle down. But then we also have to stratify to see if it's of concern or like if they need more support with the symptom they've presented with. So in identifying features of sciatica, we're looking into unilateral or neuropathic leg pain radiating below the knee. We're also looking into leg pain for the dermatomal pattern. We are looking into numbness, paresthesia, root distribution, that is L4S1, and we're also looking into weakness or any changes with the reflexes in myotomal pattern. And we're also looking into like reproducing symptom of leg pain with like neural tension tests which the most common one is the straight leg raise test. So we kind of look into like the differences between the radicular pain and radiculopathy. So when we talk about radicular pain, what do we mean? So it's when we've got dorsal nerve root compression or irritation, which leads to a reduction in the blood flow and causes nerve inflammation, and then it causes abnormal pain and sensory
Hello, ma.
signaling.
Hello, ma.
Yes.
Bisola,
Please,
Bisola,
hold
please
on.
mute
Let
your
the
mic.
moderator take care of this person. This is we can't hear you. We are straining to hear you amidst the noise. Let's take care of this noise first, please. It's no
Thank
longer
you.
making sense.
Yeah, thank you. Because I'm also, I'm like, I struggle with the distraction. So the moderator maybe should look into it if we can continue. If it's okay, then I can continue. The moderator will just let me know and I can continue. Can I carry on? Should I continue?
Yes, ma. Proceed. Thank you.
Thank you. Thank you. So we're looking into radicular pain, like the differences, like when we say radicular pain and radiculopathy, what do we mean? So with radicular pain, this is like the dorsal in radicular pain, we've got the dorsal sensory nerve root being irritated or compressed, and this leads to reduced blood flow and then nerve inflammation, and then abnormal pain and sensory signal will be sent, and then sensation, strength, but then sensation, strength, and other and reflexes, the ankle and the knee usually remain normal, but leg pain often worse than the spinal pain. So if we're talking about radicular pain, there might not be pain in the lower back, but then there might be pain, the pain will be more in the leg. But then if you check with the neuro symptoms, the strength is intact, the reflex is intact, and the sensation is intact. What we've got is more of pain going down the knee, sometimes into the toes. It often settles down with first line of management. But in the case of radiculopathy, the nerve signal is interrupted by a mechanical compromise. So let's say there is obviously for mechanical reasons, which we will discuss moving further. Then in radiculopathy, again, the objective sensory changes may be present. So unlike the radicular pattern in radiculopathy, there will be changes with the myotome, changes with dermatome, and then changes with reflex. So these are the like basic difference between the radicular pain pattern and radiculopathy. Less common, sorry, yes. What are the common causes of sciatica, like the radicular symptoms? So when we talk about that, then we like looking into the most common causes, obviously, which is herniated intervertebral disc, commonly L5, S1, and then it's often age-related rather than like trauma. We're also looking into causes like spondylolisthesis, where the proximal vertebra move forward and relative to the distal vertebra. And then we're also talking about spinal stenosis in case of central or lateral canal narrowing. Then less common causes of sciatica include infection. This can be in the form of discitis or vertebral osteomyelitis or epidural abscesses. And then other causes can be cancer. Obviously, metastatic diseases is more common than like the cancer being primarily from the spine, like cancer being primarily from the spine. And we also got non-spinal mimics like the hip, the vascular, and the peripheral nerve causes that might be causing the sciatic pain type, like, and yeah, just go. So when we see the patient, like when a patient present to us, obviously we need to do our own assessment subjectively and objectively. And what are we looking for? We basically need to observe deformity, abnormal curvature, bruising, contusion, and also the gait pattern. The first thing obviously we see is the gait. So any antalgic pain pattern, any offloading pattern, any pain behavior like all this we need to observe. And then we also need to look into the neuro aspect of it, sensation, paresthesia, myotomal power, and reflexes. And we'll also also look into movement related pattern, like reproducing the pain, as with flexion related leg pain may be suggestive of nerve root irritation, but then with extension we might be thinking toward facetal arthropathy or stenotic pattern. And we also have to screen for other like joints or other things that might be mimicking sciatica. So let's say with the hip, we've got to screen it to see if the pain might be from the hip rather than like disc pathology. And we've also got to do the neurodynamic testing. Obviously, the straight leg raise is the most common one, and it's highly sensitive and specific. The slump test also, when clinically indicated. So again, differential diagnosis, we think beyond the disc. We think more likely differentials could be maybe deep gluteal pain or the piriformis syndrome. We also think greater trochanteric pain syndrome. We also think hip osteoarthritis and facetal arthropathy, and we also think spinal stenosis, which all can be ruled out with our objective during our objective assessment. And then less likely other differentials for radicular pain will be myelopathy or higher cord compression, peripheral nerve palsy, as in the case of peroneal nerve at the fibular head, also metastatic neoplasm and pelvic mass. Also, vascular claudication. We're also looking into things like avascular necrosis of the femoral head that might be causing symptoms of back pain. And we're also looking into the SIJ pain as well as like sacroiliitis, which is associated with axial spondyloarthropathy. And then with this, we move into our next aspect of the presentation, which is looking into the spondyloarthropathy. So what is spondyloarthropathy? So it's a kind of somehow confusing when we've got impatient and we're thinking it's spondyloarthropathy. Some say it's spondyloarthritis. Which one is which? So spondyloarthropathy is also known as spondyloarthritis, and it is like an umbrella term for a group of related inflammatory conditions which have overlapping clinical features and overlapping risk factors as well as immunopathogenesis. And when we're looking into spondyloarthropathy, so we're looking more at the manifestation, like with the manifestation, then we are able to, when we look into the manifestation, then we are able to label the patient as having one type of the spondyloarthropathy. So with manifestation of like we look into three manifestation. We've got the peripheral joint manifestation. So with the peripheral joint manifestation, we've got three major ones, three ones like the arthritis. So unlike in rheumatoid arthritis, with spondyloarthropathy, arthritis is the oligoarthritis. That's what we are after. So it's more the bigger joints than the smaller joints, which is in the case of rheumatoid arthritis. And also we're looking into the end inflammation in the enthesis, like in the Achilles or the heel. And we're also looking at dactylitis, which is very rare, but then it's like swelling in the toes, which is also known as sausage digits. So that's it with the dactylitis. So when we're looking into peripheral joint spondyloarthropathy, then we're looking into inflammation in these three areas. With the extra articular manifestation, we're looking into change inflammation in the eye, which is most commonly known as uveitis. So with uveitis, it's the features include like redness of the eye, painful eye, sometimes blood vision. And when we've got individuals with these symptoms, it's like an emergency for ophthalmology review just to prevent complete loss of the eyesight. And we've also got psoriasis, which is also another autoimmune skin disease, and then inflammatory bowel disease is the inflammation of um the hello can which is the inflammation of the bowel mucosa. So the two important, like the two inflammatory bowel diseases are the Crohn diseases and ulcerative inflammation of the colon. So that's it. That's the inflammatory bowel diseases that we've got. So sometimes we ask the patient, obviously, if they've got such underlying or undergoing disease, and then we can somehow categorize what we've got or according to the manifestation. And then we move to the axial manifestation, which is inflammation in the spine, in the sacroiliac joint, and axial engesis. With that, we move to the main one, which is the axial spondyloarthropathy, which is our main focus for today. It is defined as an inflammatory condition affecting the axial skeleton, particularly the sacroiliac joint and the spine. And it is the key presenting features is inflammatory back pain. But then when we talk about axial in spondyloarthritis, sometimes we get confused because sometimes it is known as radiographic axial spondyloarthropathy or non-radiographic spondyloarthropathy. So when we talk about radiographic, it is it means that the sacroiliac, there is inflammation visible on the X-ray, and then we classify that as radiographic spondyloarthropathy. So in the individuals that even with the X-ray, the inflammation in the sacroiliac joint is not visible, then we classify them as a non-radiographic spondyloarthropathy. We classify that as non-radiographic spondyloarthropathy. So with those individuals, usually MRI is the best thing to to be able to diagnose the inflammation going on in the spine. And the radiographic axial spondyloarthropathy is also known as the ankylosing spondylitis, which we are all familiar with. The key thing is a normal plain X-ray does not exclude early or non-radiographic axial spondyloarthropathy. So some individuals will come and then we'll have X-rays and then there will be no any sign of inflammation, like any sign of axial spondyloarthritis. But then that does not mean they don't have it. Like we have to, especially if the clinical pattern, if we look into the clinical pattern and they're kind of fitting in more towards the family of the axial spondyloarthropathy. So when are we to suspect axial spondyloarthropathy? With inflammatory back pain pattern, we're looking into back pain that is lasting for more than 3 months, and the onset is usually before the age of 40 to 45 years. So young individuals with back pain for more than 3 months, and then insidious onset, which is more worse at night or early in the morning, and sometimes associated mostly with stiffness, but then it get improved with movement. Then these are all futures, these are all patterns that we need to look into. If we've got an individual or a patient with this sort of pattern, we should like consider inflammatory back, like spondyloarthropathy. And then sometimes they might like report alternating buttock pain, and then for some reason they might say, but then taking non-steroidal anti-inflammatory help ease the pain. So again, we also need to look into associated SpA futures, like for the peripheral manifestation and extra articular manifestation, which we've already discussed previously. So when we are diagnosing axial spondyloarthritis, it is based on recognizing the clinical pattern, and which in turn is supported by the blood test or imaging, and then maybe rheumatology assessment. So in terms of the blood markers, the clinical pattern are what we've just what we've just mentioned, the slide before this one. And then in terms of blood markers, we're looking into CRP and ESR, but this may support the inflammation, but they can also be normal. So because they can support, an individual can come with raised CRP and ESR, but then they are not having ACL spondyloarthritis, because this blood markers can also be raised in cases of obesity, in cases of other infections. So we also need to put that at the back of our mind, that individuals coming in and then we maybe request the blood and then we've got raised CRP and ESR, that does not mean they automatically fit in like they're having ACL spondyloarthritis. Again, if they are not, if the markers is not raised, again, it's another thing. We are not to rule out that they don't have it. So either way, we still have to look into the clinical pattern. So another useful one is the gene. It's very useful because positivity is strongly associated, the HLA-B27 gene, so its positivity is strongly associated with ACL spondyloarthropathy, but then a negative result does not fully exclude it as well. And then we go into the X-ray of the sacroiliac joint. Like I said, it may show radiographic sacroiliitis in the established disease, and in some individuals, it will not show. So the fact that X-ray did not show does not mean an individual does not have ACL spondyloarthropathy. So we also need to, again, look into the clinical pattern and consider further imaging, especially if the clinical pattern is more fitting that yes, this patient is more likely, the chances of this patient having spondyloarthropathy is high. So we can move to the MRI, which is important very important when the X-ray is normal, but clinical suspicion remains high. That's it. So recognizing SpA features in darker skin tones. So, when we talk about the manifestation, the different manifestation, we talk about the peripheral and other extra-articular manifestation. So we talk about uveitis. I just think there is a kind of difference in the light skin and then the darker skin tone individuals. So when we're looking into uveitis in the light skin, it's like very much obvious compared to in the darker skin. So like just a form of putting it at the back of our mind that there might be variation in how this might present. So we shouldn't not only rely on the visible redness of the eye, but we can also ask about the pain in the eye. We should also ask for about photophobia, blurry vision, if the eye is watery, and if there is any previous episode of eye pain. Then suspected acute anterior uveitis needs same-day ophthalmology assessment, like I've said before. And in the case of dactylitis, I think this one is quite okay. We recognize this can be recognized by whole digit swelling, the contour changes, warm tenderness, just like a sausage-shaped toes. It's very easy to identify, but then we also have to rule out other possible causes of swelling in the toes. So, and comparison with also, yes, we should also compare with the other side of the foot. We should also look for associated SpA features. So not only are we looking into one, we also looking at other manifestation that might be possible, because spondyloarthritis in spondyloarthropathy, like the features are overlapping. When one is there, one might be there or one might not be there. So we just all need to be looking into the pattern. And with psoriasis, also in darker skin, it's plague may appear the brown, purple, gray, or violaceous rather than the red as it is. And then we also check for scale, plaque thickness, and distribution, and also the nails. Yeah, the most important thing is like sometimes the features are more apparent in the nail, so we look into the psoriatic nail changes as well to try to rule out the peripheral manifestation. So with this, we move into the third aspect of it, which is the risk stratification and imaging. So when we talk about risk stratification is like the process of identifying a patient's risk of poor recovery. So management can be matched to their level of need. And with risk stratification, what are we considering? We consider the pain intensity and the functional limitation of the patient. We also consider the duration and progression of the symptoms. We're also considering the neurological symptoms that are present, if any, and we're also looking into psychosocial factors. So with psychosocial factors, we're looking into the thought of the individuals, their emotion, their belief, their behaviors, and their social circumstances that might influence how the patient responds to the back pain. And we're also looking into the work and activity impact. So the work of an individual can also affect their recovery. So let's say they need their work is more of repetitive activity that strain the back. So obviously we need to look into this as well, see how we can help the patient and with work modification so we can optimize so we can like kind of have a better outcome or recovery. And then we're also looking, considering fear avoidance and the low mood. All these can affect the recovery of the patient. So if the patient is scared of movement, so that's another thing, especially if we've like if we like know that this is not something that will cause further damage, obviously following our assessment. So all these are what we consider in stratification, and also we consider previous response to treatment. So in primary care, we use a common tool to kind of stratify this patient, and it's called the start-back screening tool. Let's see, yeah, that's it. So it goes just like this. It's something like this. So I think you just ask the patient, obviously, and then at the end of the day, the scoring is categorized into three: the low risk, the medium risk, and the high risk. So yeah, it's going to be in the slide anyway, so we can all go through it. It's very easy to use. It is used as the first point of contact to identify risk of persistent disabling symptom and guide matched care. So clinical judgment still matters. So we're not only considering this, we are also considering other clinical outcome like objective assessment we've done with the patient. And then, like I said, we categorize it into like with the start it's like three categories: the low risk, the medium risk, and the high risk. So with the low risk, they're likely to recover well. So management focus on reassuring the patient, educating the patient on the back pain, keeping active, how to keep active, self-management advice, and safety netting. Obviously, with low risk, it's not only with low risk, but with all our patients, I think it's very good for us to always educate and empower them on their condition. That way they will not be more anxious, because some individuals or some patients get more anxious and then go into Googling, go into asking ChatGPT, and before you know it, they're very much anxious again. It's like compounding on their issue. Like something less serious might be exaggerated because of, so it's a very good thing for us to always educate them and yeah, safety net them, which is the best. And then with the medium risk, they may need more structured support in their management, which could be in the form of exercises, function restoration, return to work support. Like I said, if the work is somehow also affecting the pain, or it's a kind of repetitive strain causing on and off pain, then that can be kind of looked into. Here we've got what we call the footnote with amendment of duty. So in individuals like this, we might recommend like amendment of duty. So let's say it's more with bending, and we obviously looking into how we can reduce the bending or prolong standing or prolong seating. We might recommend change in the duty of the patient. So it's just a form, you fill it, and then the patient present it to their workplace, and then a sort of amendment is made to suit their need for the time being while they get better. Sometimes it's not just amendment in the type of work, it's with the timing as well. Maybe a bit of reduction in the timing. So instead of 1 hour straight, maybe just getting it low to 3. The basic thing is the patient is still active, because the patient is still active. So we're not saying the patient should not work completely because they've got back pain. No, just a basic amendment that we can do to support the patient going back to work. And then, of course, follow up if not improving. And sometimes even if improving, just to see how patient is going on and how the patient is coping. And then we move to the high risk patients. With the high risk, they've got persistent pain and disability. So the management not only focus on pain on pain optimization, also looking into psychological informed care. We're also looking into addressing the fear, avoidance, their low mood, and then graded activities for them, and also more intensive support. So with these individuals, they need more intensive support, more close monitoring. So mostly here we send them to the MSK pathway. So it's not like giving them from the primary care, giving them reassurance, giving them exercises, and then seeing them for a follow-up in the next one. So because we know they need more support, then we send them down to the MSK pathway where they can have a full session of rehab, closely monitored, and then as they get better, then they can be discharged from there. But another thing to note is that high risk does not mean we need imaging. It means there is need for more target support. So a patient might be a high risk individual, but then that does not mean because he's high risk, then he needs imaging. And with that, I just want to kind of hear our view on the imaging. Like, what do you think is the like approximate cost of lumbar spine X-ray or lumbar spine MRI? I don't know how, like, what do you think is just 1 or 2% just to give an idea how much does that cost before we move into the next stage? Hello? Any idea how much does lumbar X-ray or MRI cost? Can anyone just share? Moderator? Should I just carry on then?
Good evening, everyone.
Good evening. Thank you.
Ma, for what we've learned so far. In my experience, for the imaging, the cost of a lumbar spine X-ray is, I think, about 10 to 50, 10 to 15.
Is it the X-ray or the MRI?
The X-ray.
It's 10 to 15,000. And the
Yeah.
MRI, do you have
But
any?
the MRI is
Yeah.
about, I think, about 90 to 120,000 naira,
Okay.
depending on where that is being done.
Yes. Okay. 90 to a kind of 120. So let's just say 100K. Let's say just 100K,
Yes.
depending. Okay. So when a patient, another question for you, sorry, please don't go. So when a patient present with low back pain, what is your usual approach to the imaging? Like you see a patient, you've assessed the patient. What is your usual approach to the imaging? Do you request for the X-ray or you request for MRI?
Most times we don't request, except if the patient is in a lot of pain, they're having radiculopathy, and then especially if the pain is on extension, then I may suggest that the patient do an MRI. And usually we're checking for stenosis. Either we're looking to see if there's any form of stenosis involved in the patient's in the degeneration going on within the lumbar lumbosacral area. And in some cases, we find that the patient might have um, a narrowing of the exit foramina of the nerves. And it's usually good to know so we know what type of exercises we're giving that patient. And in some cases, we also find um, that, but there are times when we don't really need it because you can obviously see from the presentation of the patient that if the pain is more on flexion, that there's a lot of muscle spasm.
Mm.
And sometimes patients have already taken the x-ray before they get to us. So we don't look at the x-ray first, we try to do our own assessment. And then at the end of that, we now try to confirm our findings with what we see on their x-ray or MRI reports. That's basically.
So assuming the patient come in with X-ray, or you request for X-ray or MRI, and then you find out it's a stenosis, like will your management plan change? Will you be thinking something
Okay.
else?
Yes. The well, the thing is, you already know that if you are having a patient with stenosis, any exercises that encourages flexion is mostly contraindicated for that patient. So we know to advise the patient not to go because patients sometimes go online. Sometimes they come back, they say, oh, my friend told me to do this exercise, or I saw this exercise online and is it good? And I try to tell them it's not every exercise you see online that is good for your condition. Because even though you might all have back pain,
Yes,
you have different
of course.
manifestations and there are different things we see going on within the spine. So mostly it's more to advise the patient on what to avoid and what kind of exercises will be good for that patient.
Are we able
Mm.
to a kind of identify stenotic symptoms in the clinic without really working on, like without really requesting on MRI? Like,
Sorry, I didn't get that question.
like I mean, with our assessment, like during our objective assessment, if we are thinking towards stenosis, I think it's something that we can always look out for with our various tests in the clinic to to a kind of put that as one of our impression. Does that make sense? Like, we don't really need MRI, but then we are looking at the clinical presentation and we are also looking at our objective assessment. If we are we able to confirm a stenosis with objective assessment only? Now the MRI is more for confirmation, right? Like, yes, for diagnosis, yes, we have a stenosis. It is like, do you understand what I'm trying to say? So basically, we can actually know that this is a stenosis even without the MRI, right? I don't know if you understand what I'm trying to say.
Yes, that makes
Good.
sense.
Anyway,
I
let's move
understand.
forward. Let's not take much time here. So,
Okay, I have a question. I'm sorry that I'm asking this question. I know that we're still I've always been a bit when it comes to facet joint issues, how do you differentiate them from um, stenosis, muscle spasm, and radiculopathy, things like that? When it comes to the facet joints, how do we um, identify that in during our assessments?
so with stenosis, we're looking at pain more with extension. Like basically, even if the patient is coming in, if there is element of stenosis, let's say spinal canal stenosis, then we might see the patient in a forward flexion. That is one thing. And they might also report that they cannot walk as far as they used to because of the pain. So walking can be one thing that exacerbate the pain, like serious pain for them. Some might come with radiculopathy, like some will come with radicular symptom or radiculopathy, depending. I think with stenosis, I would say more of radiculopathy. You look into the neuro aspect of it. If there is any compromise with the dermatome, myotome reflexes, then you think this is a serious stenosis going on. But then if it's a radicular symptom, which following your neural assessment, you feel it's not a compromise, like there is no compromise, there is no significant compression that's compromising on the neuro aspect, then it's something that definitely I don't think your management plan will change. Again, with the facet joint, yes, with extension, you can get the pain of the facet joint, but depending on the age of the individual as well, and depending on the activity type of the patient, like you, that's when you also think facetal stenosis, facetal arthropathy can all get like can all lead to pain in the lower back. But what you've got to do is correlate it like with the dermatome, like the radicular pattern and the radiculopathy. So whichever fits you get, that will determine your next line of like your action, your next line of management, and if really you need to do imaging. The reason why I bring this topic, like this question up, is to ask how much does it cost to do the MRI or the X-ray is obviously we are managing patient with low back pain. Now think about a patient who is coming here, they've got like free X-ray, free MRI. But in cases where the patient will be the one that have to pay for the MRI, have to pay for the X-ray, and then we are saying that we are just sending the patient for MRI and the X-ray just so we can confirm that we are having a stenosis or a radicular pain or like degenerative changes or spondyloarthritis or spondylosis. You get that our management plan will not change. In individual with low socioeconomic status, we are further compounding their issue. There will be more burden, like I've got a back pain and now the money aspect of it just for me to get this done. Like they will feel like if they don't get that done, then their condition will not change. While in the real sense, we can still manage those patients and they can still be better even without the imaging, because the imaging is not really going to change anything in our line of management. So we're just going to move into it. You will discuss more further as we go.
Hello.
Yes?
Hello.
Yes.
Good evening. Please, I have a question.
Yeah.
What about cases like spondylolisthesis, where imaging is necessary to guide the kind of exercises we are going to give them?
Spondylolisthesis, to guide the kind of exercises that what exercises are you thinking in cases of spondylolisthesis? What is the patient presenting with?
Probably, let's say, is retrolisthesis.
Like, yes, we're thinking retrolisthesis, spondylolisthesis.
Yes.
What is the presentation? What is your objective findings? Do you get my point?
Okay.
So it's not, I'm
Yes.
thinking is a spondylolisthesis. Yes, it's a spondylolisthesis, but is it that severe that need intervention, like spinal intervention? Is it that severe based on the patient's presentation, based on your objective assessment? Is it compromised that definitely this is not a patient that will just go for like exercises, activity modification, and other pain like modification, like pain optimization? We just have to look into another form of management for this type of patient. Basically, when we are thinking about imaging, like we don't image because we want to confirm that yes, this person have got cervical spondylosis or this person have got lumbar spondylosis. Yes, even with normal, even when we MRI or when we image a young individual, let's say anything from 20, 25, we're expected to see some changes. And then And then that individual might be asymptomatic, nothing, but then there's still like degenerative changes, I will say, in the spine, but nothing is happening. Do you get? So if coincidentally you just find that degenerative changes, and then patient, you're not telling patient that, okay, you've got some degenerative changes. Some patient might not really take it the way you are thinking. You as a physiotherapist, okay, you've got degenerative changes. Obviously, you might get pain here and there with some activities. If you do this, it might just give you a bit of flare up. You need to improve maybe the strength, the stability, core strength, and other stuffs you need to do just to make sure that maintaining a healthy lifestyle, not to put on too much of weight. All those activity modifying. You as a physiotherapist, you know that yes, if I do all this, it doesn't really matter. Like nothing will, it will not really change anything. The patient will still be living. But the patient might think, oh, they've said I've got degenerative changes. It means my disc is squashed, is this, is that, depending on how you also communicate it to the patient, depending on what language you use to communicate it to the patient might be more anxious. I've got a spondylosis, I've got a spondylolisthesis. They said I should not bend. Now I'm not going to bend. And then any small pain, which might have settled down maybe with a rest, maybe use of heat pack, gentle stretches, then the patient might like exaggerate, over medicalize somehow, like they will take more of medication. And before you know it, when the actual pain come, and their body is now resistant to the use of medication. So there are a lot of reasons why we are not just go for like imaging. One, financially; two, psychologically; and other factors that might just compound the issue for us as the physiotherapist and also as the patient. Yeah. So when not to request imaging, let's carry on. And then I think as we go on, we'll understand more better where I'm coming from. So do not routinely image when the presentation is consistent with non-specific or mechanical low back pain. Obviously, you've done your assessment as a physio. This is more fit like non-specific, it will get better, settled down, let's say in a week or two. Latest 6 weeks, it should go down. You don't have any red flag present, so we are good. We don't need to image. Obviously, if we image, we might see a bit of changes, but that does not make any difference to what we are going to do. And neurological examination is normal. We've checked the dermatomes, the myotomes, reflexes, all normal. Then if I give you an imaging, then I'm going to say, oh, okay, I'm just going to confirm that yes, it's a stenosis. But then the neurology, the neuro symptoms, everything is like objective assessment, everything is fine. And then still I'm sending you. I've also screened for red flag, like no red flags. And if I'm thinking stenosis based on my objective assessment, then I should be able to give exercises as a physiotherapist that will help that patient. Like I know the type of exercises that I will give that will not make it more worse. Rather, it will improve the symptom of the patient, and then educate the patient on what to do, what not to do, how to keep more healthy. So I don't think we need imaging. Again, you should not image if it will not change the management. That's what I've been saying. And then the request is mainly for reassurance. Again, if I'm just thinking, okay, it's just to reassure the patient, that nothing is happening. We are professionals, professional enough to sit down the patient. Here, mostly if you're doing any test, you've got to tell the patient why you're doing the test, what you are looking for. So if you are looking for any compromise in dermatome, myotome, and you've already told the patient, I'm going to be checking for your sensation. So if there is any compromise, then this we know that something is happening, or I'm going to be checking for your reflex. I'm expecting this to happen, and if it doesn't happen, then it means something. Or if it's exaggerated, this is what something is happening. We need to check as well. I'm also going to test for your power, for your strength. This is it from 0 to 5. So as the patient is doing it, yeah, what do you think? This is a power of this, and then the patient, already you are reassuring the patient. Like you don't need the imaging to further compound it, like yes, I need the imaging to confirm that, like, this is something. Then I do the reassurance. Obviously, at the end of everything, all you've got to do is safety net the patient. Yes, at this moment, we don't need imaging, but we need you to know something when we need the imaging. So this is it. Then you can list all the safety netting for the serious spinal pathology, and then patient knows at the back of their mind. What you don't know, that is when you start searching for. So they will not search more for like, I've got this symptom in ChatGPT or I've got this symptom in Dr. Google. So that makes it more easier for you to manage. Like I said, this is why in the other side, we've got reason why we should not image. Imaging findings are common in people without pain, and abnormal findings may not explain the symptoms, which is what I've been saying as well. Unnecessary imaging can increase anxiety, and it may also lead to over-medicalization and unnecessary referral. Okay, you've imaged, you've seen a stenosis. Yes, this can be managed. Stenosis, if it's not causing any neurologic like if you're not having any neurological compromise, I don't think you should be thinking of spinal input. Something you can manage within physio MSK MSK team, closely monitoring the patient. That is when why we stratify them. So some patients need more close monitoring. So that is it. So you just stratify the patient, look, screen out for red flag, know who you are to send, like why you are to send. Obviously, I'm not sending for any reassurance. If I'm sending, then definitely I'm sending because I know my management plan is going to change, or because I'm thinking this is a serious spinal pathology that needs spinal input or other MDT input. So that's it. And then we move to the other one. This is just like a simple flow chart just I made. So patient with low back pain with or without leg pain, you screen for any serious pathology, and then you identify the pain pattern, and then you risk stratify, and then you decide the management intensity. Where are you going to place them? Low risk, medium risk, or high risk? Am I going to refer them for imaging? But then imaging should not answer a should answer a clinical question. It should also only be for diagnosis, for urgency, because I'm imaging because this patient need urgent input by the spinal team. They need urgent input by the oncology or by the rheumatology, and then management or onward referrals. Like management plan will change or they will need onward referral, like I have said. So this is another table I've just made, like appropriate imaging for low back pain. So let's say we've got a patient that comes in with non-specific low back pain, and then we've done our examination, everything subjective, objective. Do we go for imaging? Do we consider imaging? No. What do we do? No routine imaging is needed for this patient. We manage conservatively, especially if there is no red flag. We safety net, and we might keep the patient like keep a closer, keep the patient more follow up based on the when we stratify based on where they are. Is it low, medium, or high? And then that's how we manage such patient. If we're suspecting spinal fracture, then we go for the first recommended imaging is X-ray, and then plus or minus CT or MRI, depending on the pathway here. Some will say we need MRI, but then the first line is X-ray, just to rule out or rule in fracture, and then you consider trauma, you consider also osteoporosis in this type of patient, you consider long steroid use, and you also consider the age of the patient. And when also you're suspecting cauda equina or you're suspecting progressive neurologic worsening, like progressively worsening of neurological symptoms. So I think that is where I will take that. I've got a patient that I think have spinal stenosis or spondylolisthesis with progressively worsening neurological symptoms. Then I'll say yes. Definitely my management plan will change, and then I'm going to go for an urgent MRI depending again on how my assessment like went on MRI for the patient. And if it's spinal cord CES or severe progressive neural, then it's a same day emergency, like the spinal team needs to look into that person. But if it's not any of this, then yes, still they need spinal referral, but then I can still close monitor the patient and safety net the patient for serious spinal pathologies just in case while we are waiting for that referral to get through, anything happen, then it is an emergency. And then when we've got suspected infection, malignancy, or metastatic spinal cord compression, again, that is spinal emergency. We've treated this last session. Again, we can consider blood and urgent specialist referral as need may be. And then when we've got persistent radiculopathy with objective deficit, again, this is it. So whatever I'm thinking it's a spondylolisthesis, I'm thinking it is disc ball disc herniation, but then I'm thinking it's more like based on my objective assessment, this is like getting worse, then still I will request. But if it is stable and if it's something that I don't think, no, it will not change any of my management. If it is, so I would know what sort of exercise I will give my patient. As a physiotherapist, I already know what type of patient to give what patient that needs what they need. Do you get? So I don't need the MRI or the X-ray to tell me that this is it, because my objective assessment, I'm confident enough about my subjective and objective assessment, and I've also educated my patient on what might change and what might get worse. So patient is aware. If any change, then definitely they will come back to me. And so I'm good. At this point, I think I will manage the patient holistically, managing the patient's pocket. Sometimes the patient will say they went for X-ray. X-ray will not really show us anything aside degenerative changes in the spine. Yes, some individuals, some we might see like listhesis, all those features we can see, but we don't know if it is like compressing the nerves, anything that will compromise. X-ray is not going to show. So sometimes we even X-ray here we don't request for X-ray for all those degenerative cervical, lumbar degenerative changes. No, what we do is we thinking progressive neurological symptom, then it's MRI. It's never X-ray. X-ray is only when we want to rule out fracture. And then again, when we've got suspected ACL spondyloarthritis, so with suspected ACL spondyloarthritis, like I said, it's X-ray, the sacroiliac joint, plus or minus MRI of the SIJ joint. So depending, some clinical pattern fits in for spondyloarthropathy, but then I went for X-ray, and then X-ray is saying no, this part is not showing anything inflammatory in the SIJ joint. And I'm like, yes, I need to really know, because I need to conclude and make referral to rheumatology, or this patient definitely I am more inclined to. And then again, maybe I must have screened for the bloods, let's say ESR and CRP high, and the HLB27, but then the HLB27 is not something we do in the primary care. So it's mostly in the secondary care, the rheumatology does that. And I don't know how much it costs in Nigeria as well. So you see, it's just trying to kind of manage the patient completely. I'm not saying like not to waste money, but obviously as professionals, we should know that these are the patterns that fit more for this patient, and this is what is best for this patient. So with MRI for the sacroiliac, if we're thinking of axial spondyloarthropathy, requesting for MRI, it's not like the normal MRI that we request. It's called the back pain MRI protocol. Like so it's called the STAR, short tau inversion recovery. It is fluid sensitive and it shows more active inflammation. So that's why when we are requesting for MRI for individual that have got, we are thinking it is spondyloarthritis, then we're not just writing referral for MRI to rule out inflammatory spondyloarthritis. No, we're going to say the STAIR T1 weighted sequence. So the STAIR is sensitive for inflammation. If there is any bone marrow edema, it's going to show. If there is any active sacroiliitis, it's going to show. If there is any inflammatory changes around the SIG or the spine, definitely going to show. But then the T1, which is the weight sequence, it's only going to show us more anatomy and structural changes. And if we are suspecting spondyloarthropathy, then we would want to know more about inflammatory changes, because we are not after some. You can see that if it is radiographic sensitive, then you will see the ankylosing spondyl, like you see the structural changes. But in those ones that we cannot see the structural changes, so we're not after structural, we are after inflammation. So T1 will also show us if there is any erosion, if there is any sclerosis or ankylosis, and if there is any structural like damage. So if we are sending for MRI to rule out or rule in rather spondyloarthritis, then we are requesting for the STAIR and the T1 sequence, and include the whole of the spine and the sacroiliac joint. So that brings us to our next slide. Okay, let's see. With this patient, what do you think? What is the appropriate next step to take for this patient? One person, any idea? We can move quickly. I think we're running out of time already. We've still got time. Hello? Anyone? So we've got a 71-year-old female with a 2-week history of severe thoracolumbar pain. Pain started after twisting to get out of bed, and it is sharp and deep. It is worse when we are lying flat and turning in bed, and she has difficulty standing upright. There is no leg pain below the knee, and there is no bladder or bowel dysfunction, and there is no saddle anesthesia. Her past medical history include COPD and osteopenia, and she report feeling tired but not fever, or there's no any weight loss. Objectively, there is marked focal tenderness over T12L1 region, and there is reduced spinal movement due to pain. There is no objective lower limb neurological deficit, and with SLR is negative, her gait is guarded gait, slow, and there is no any systemic sign on observation. What is the likely clinical pattern? Like, where will this woman fit in? Would she fit in mechanical back pain, radicular back pain, radiculopathy? Like, where will she fit in? What do you think about this patient? And what will be your imaging decision? Will you refer her for imaging? Will you refer her for MRI? Will you refer her for X-ray, CT? What will you do? Will you even refer her at all for any imaging? And if you do refer her, or if you do refer her, or if you don't, what will be your plan with this patient?
I think there is no need for referral.
Okay, so what will you do, sir?
Hello?
Yes, ma.
Hello?
Yes, ma.
Okay. So I think I'm going to refer her for X-ray because of the past medical history of osteopenia.
Okay.
So
And if you're referring her for X-ray, what are you looking for? Degenerative changes? Anything you're thinking? What are you thinking? Why the reason for X-ray?
Because of
Obviously, you're going to refer her. You're going to
likely a
say,
pathological fracture.
because of the osteopenia, there could be fracture.
okay, so you're referring to rule out or rule in fracture. Good.
Yes.
Okay. And what will you do with the imaging when it comes back to you? Obviously, they're going to bring back the report to you. What will you do? What will be your decision? What
Okay.
the plan?
After,
Yeah.
since
First,
if the imaging comes back, if the X-ray comes back
Yeah.
positive, if there's fracture,
Yes.
then I'm going to put on conservative management. Since from the findings, there's no PSLR is negative, there's no neurological deficit.
Yes.
So just
Conservative management.
conservative management, yes.
Okay. And after conservative management, are you going to discharge her? Like, what next? Conservative management, what will you be looking into when you're managing this patient? Like, what will you manage when you say conservative management? What will you manage?
Firstly, the pain.
Okay.
Yes. So if the pain gets better, we can then move into exercise that is within a limit, what she can tolerate at that moment.
Good. Thank you. So I think we should just move on, right? So for you, you suspect fracture, and with fracture, you're going to request for X-ray, and when the X-ray comes back positive, you're going to manage her conservatively. I would say yes, and I would say somehow we need to improve on your management plan. So because this patient is past medical history, when we look into it, we've got COPD. I will look more into her medication. How is she managing this COPD? Is she on steroid? If she is on steroid, for how long has she been on steroid? That's one thing that will also affect my management plan. And for osteopenia, so I'm thinking osteopenia. Osteopenia, how is she managing it as well? Anything for the bone density, anything, is she on calcium, anything, any medication? Because this is osteopenia, it can get to osteoporosis, and this patient is COPD. So if she is long-term steroid use, then it can, like, we can progress from osteopenia to osteoporosis, right? I will request for, like, I will request for X-ray, rule in, rule out fracture. And then in my management with fracture, I will definitely refer her for bone health fracture clinic. So here it is, yes, within my, like, it is a physio, as a first contact physiotherapist, like, you rule out for red flag and then you do what is needed. As a first contact in the primary care, I don't manage fracture, so I'm going to send her to the fracture clinic. Now, if in the course of her management, they decide she needs physio, then they refer her for physio with the hospital. Like, there are physios in the hospital that take care of that. So within my scope as a first contact, I don't manage fracture. I can manage somehow the pain, liaise with the GP to optimize the pain, maybe pain medication. And at the first instant, I can also, like, I can advise her on what to do, what not to do, and also safety net her just in case it's a stable fracture. Do you get? It might be a stable fracture, but then I will also be concerned of displacing something. So the best thing is either referral, immediately thinking about fracture referral, urgent referral, X-ray, or urgent referrals, fracture clinic. And then I will also tell the GP to look into her bone health. And if she needs a referral to the bone clinic, like bone osteoporotic clinic, that will also be done. So you don't only look at what can I do as a physiotherapist manually, like hands-on. You see, it's a multidisciplinary team. Even you spotting that this is happening and actioning it, you've already done something as a professional. So it's not until when I give her this exercise, until when I say she should do this, that is when I feel, yes, I've done my work. Even spotting that red flag, even spotting that need for her to get this sorted out, I have answered it, like I've done my job. Do you get my point? So we move to the next slide, which is just a discussion of this individual. So what will raise my concern is the age, the sudden pain after a low force movement like stress fracture, COPD, long-term oral steroid osteopenia, like I said, and then focal tenderness when I palpate, and then pain worse with lying flat and turning in bed. All these are features that we definitely make someone to think towards fracture. Likely approach, suspected vertebral compression fractures, request appropriate imaging according to the local pathway, and then common X-ray first line, and then assess for bone health and pain control. And that's it, what I will do as per physio, as per FCP. And why not a routine MRI? There is no clear radicular deficit or CES pattern, so I'm not going to request for MRI. However, MRI or CT scan might be considered in neurological features. Let's say if she comes in with other neurological symptoms, then I might consider an urgent MRI. Although I'm also questioning, I'm querying fracture, but with neurological symptoms, I might think in something far more beyond only fracture, maybe another thing compounding the issue, and then I will want to know. But then it has to be urgent. And then if there is any features of malignancy or infection as well, that should all prompt me towards MRI. Then we've got to the second second case study. What do you think is the most appropriate for this patient? We've got a 76-year-old female with 4-month history of gradual onset of low back pain. Symptoms have recently worsened and now affecting mobility. Pain, it's radiating into the left leg and occasionally felt in the right leg. She reports intermittent pains and needles, which with increased urinary frequency, which she feels is age-related and long-standing. So it's not something new, it's long-standing, and to her it's age-related. Obviously, she's 76, pelvic floor muscles gone weak. There is no change in her bowel function, and then there is no saddle anesthesia. But in her past medical history, cervical cancer, she's still under oncology follow-up, and she's got type 2 diabetes, but then she's stable, and she's also osteoporotic. She's currently taking calcium and vitamin D, and the last bone densitometry scan was 6 years ago. That's a brief subjective history. And objectively, you find out that she's got positive SLR on the left, reproducing back and leg pain. You've got dermatome all normal, but then reduced L4, L5 myotomal strength 3+, and then palpating over L2 to L5 and the gluteal region, all reproduce pain like you when you palpating, all painful. What is the likely pattern like? What will you do decision-wise regarding imaging, and what will be your plan? Anyone?
I think this patient needs multi-team, multidisciplinary approach.
Okay.
First of all, there's need for X-ray first. At least from your own part as a physio, you check the level of the pain where you think, especially F5 region.
Yes.
In order for X-ray, check, do your own part, and then other things, because there are cancer patients, you can see all red flags are also there, other things. So do your own part, and then diagnose what you can diagnose through the X-ray. There is changes in the spine, whether there is bone degeneration of the discs or osteophyte, all those things you checked.
Okay.
So if there are, then you do your own part, and then if there are things associated with red flags, you refer. So
So
good evening. Good evening.
Good
Okay.
evening, ma.
Good evening. I wanted to talk.
I just wanted to, excuse me, ma, sorry. I just wanted to confirm
Okay.
something from him and then you will talk. Sorry, just a moment.
Okay.
Thank you. So, sir, you're saying you likely going to send for X-ray, but if you send for X-ray, what will you be looking for?
Yeah, you check for changes in the spine, the
Okay.
disc. Yes, the disc. You check whether there are bulging discs, whether there are osteophytes there.
Okay.
May likely causes compression.
Okay.
And
So
her
if
age.
Hello.
intact, then I think that is not that's not your concern, because
Okay.
you can refer. You expect red flag in this patient because
So
patient that
where
is
will you
for
be
cancer.
referring to? Sorry. Where will you be referring to?
It's a multidisciplinary team. You refer to the medical team
Okay, when you refer
for
to
red
the
flag.
medical team, what will you be asking them to do? Review her for what?
Yeah, you review her for there may be this radiating pain from there is a cancer patient. You expect radiating pain somewhere, which is
Okay.
not necessarily from the
The
spinal
pain should be
structures.
worse.
Hello.
Yes.
Yeah,
Okay.
not necessarily from the spinal structures. Maybe if you check
Okay.
if it's intact, then you don't expect the problem is from the spine.
Okay, sir.
Hello.
All right. Yes, ma.
Okay. Okay. Well, for me, I would say she's having sciatica. That's more of radicular pain because SLR is positive and the pain is radiating to her knee. And the buttocks, there is also pain. So it's more of sciatica, and I will manage her as a physiotherapist for that.
So
Since she's already on her cancer treatment, and so I will just manage her for the sciatica.
good, ma. So you're saying she's having sciatica and it's of radicular pattern? You think it's more radicular than radiculopathy?
Yes, it's more because the it's not even if there's because they say there's and some amount of my myotones they are affected. So, but it's not that serious. It's not. It's tilting towards a radicular pain,
Mm.
not a radiculopathy. So I think I will manage her as a patient with sciatica.
Okay, so ma, just to clarify something, when we're talking about radicular pain, yes, it is pain in the leg, maybe no pain in the back, maybe with pain in the back. But when we're talking about radiculopathy, then there will be neurological compromise. Any of these three, dermatomes, myotomes, or reflexes can be compromised. And a power of 3 plus she's having at the time of your objective of assessment. And you feel she's tilted towards more radicular pain. You know, sometimes 3, it's considered as a foot, like when we've got a power of 3, it's considered as a weakness, because if it is
Okay.
3 plus and then the patient start to walk before they get to a certain stage, like a length or in their walking, that 3 plus might drop to 3 or even less than 3. So you think you can consider this myotome as negligible, like it's not that much of a concern? Do you get my point? So it's still tilting towards the radicular for
If I can come in, please.
yes. Yes, ma.
Because of the history
Hello?
of the cancer, the
Yes.
neurological symptoms,
Yes.
I don't think you could just assume it's a simple mechanical low back pain and manage her as a physiotherapist. I
Okay.
think maybe she might need urgent medical review so that you can rule out other serious pathologies, maybe a metastasis from the cancer.
Okay.
So maybe you need to refer her for a medical assessment.
Okay.
Maybe you send her back to the unit that she's receiving that follow-up.
Okay.
And then maybe she needs examination for the cauda equina syndrome because of that radiation of those neurological symptoms.
Okay.
She might require MRI of the spine.
And if you're
then
requesting
if
for
you get
MRI, is it going to
clearance,
be urgent or like a routine MRI? Would you say?
I would say maybe she would require an urgent MRI.
Okay. All right.
Yeah, that's
Good.
my thought. Then maybe if she's ruled out, no metastasis, nothing, and then you can just manage her normally as a physical therapist.
Good. Thank you. So if there is any issue, then you do the referral to the appropriate pathway. Otherwise, you will just manage her as a physio. Good. Thank you. And someone want to talk again?
Yeah, thank you, ma'am.
Mm.
In this case, the first thing I would suspect, looking at the past medical history,
Yeah.
that this patient is undergoing oncology follow-up,
Mm.
I will first and foremost suspect compressive myelopathy,
Okay, metastasis.
possible metastasis coming, and then spinal fracture resulting into myelopathy. And then looking at the myotome, 3+, it means that this is a red flag for MRI to investigate if there is cord compression. And so the likely clinical pattern is compressive myelopathy. Imaging decision, I will have to request for MRI to confirm cord compression.
Yeah.
And then once that is established, then I will have to refer this patient for, if it is established that there is a case of metastasis, then the patient will be referred for palliative care. Thank you.
Thank you. And will your MRI be urgent or routine?
It will be urgent. It will be urgent.
Thank you, sir. Any other thought? I think we've still got time, so we almost. Any other thought, or we should just move on? We good? All right then. So what are the concerns raised regarding this patient? The history of cancer with ongoing oncology follow-up, which virtually all of you have mentioned. Progressive pain and declining mobility. This is a concern. Objective myotomal weakness, pain radiating into both legs at a time, although she said it's more on the left, but sometimes she could have it on the right as well. Then the history of osteoporosis with possible fragility fracture risk. That's another thing to also consider. And urinary frequency, which may be long-standing, as she said, but then it still needs careful clarification. So with this patient, I think based on our last session, like we've looked into the serious spinal pathologist. I think she fits in more in the metastatic spinal cord compression, and then it can also be like a compressive fracture because of her osteoporosis. We also thinking towards that. And yes, what is the approach? So we consider urgent MRI, particularly to exclude the metastatic spinal cord compression or spinal disease or any other serious spinal causes, as we've mentioned. Osteoporosis also keeps a vertebral compression fracture in the differentials. But then in this manner, I'm not going to say X-ray. It should have been considered, but then because of the case in the myotome and the dermatome, I don't think X-ray is going to give me more. Like X-ray will tell me more about what is going on in the spine. So I will consider MRI is more clinically useful for me to rule out cancer history and neurological deficit. So if I'm thinking of degenerative changes, she is 76. I'm expecting it. So I don't think anything like I'm expecting degenerative changes, obviously, but then with the red flags that she's presented with, it's urgent MRI for me. And another thing to note is you should not anchor it to sciatica when there is cancer history or any progressive functional decline or objective weakness are present. So if we see any patient with a previous history of cancer, yes, we should rule out objectively, we should rule out like serious spinal pathology, we should screen out. But if there is neuro involved in this patient, I don't think it's something that we should manage as physios. Like, no, we should look more deeper. We should try to like confirm the diagnosis, know what we are really dealing with before we can carry on. Obviously, we can give some advice regarding pain modification, pain optimization. We can give advice regarding modifying activities just to ease the pain and safety net the patient. But then it's either an urgent MRI, or if concerning, then we should bring in the GPs or the multidisciplinary team, other members. It could be a referral to the spinal team. It could be a referral to the oncology team, just to make sure that we are managing the patient holistically. So another last one. I know. So sorry. I hope this class is not boring with my case studies today. So the
Can I
last
ask a
one.
question?
Yes.
Okay, so in the typical case study so far, the past medical history of either osteoporosis or osteopenia is there, but say the person has not had that diagnosis officially, how can you recognize that?
Then you check for the age of the individual. When are you expecting an individual to be osteoporotic, osteopenia, and what gender do you think is more at risk, like have high prevalence? It's more the female menopausal age. So you look at that. If you're thinking this could be osteoporosis or osteopenia, you could change for, sorry, you can check for other with the bone health to confirm if this individual is actually having osteopenia or osteoporosis, and if it can affect or if it can compound to what we are having at hand. Do you get? So if it's not a well-established osteopenia, osteoporosis, you as the physio, you can suggest bone health check for the patient, and then that can be checked and well documented. Then we have it on record. Patient have got this, or we've ruled out this. Just look into the age of the patient, look into the gender, and look also into will I say the ethnicity of the patient. Yeah? Can I carry on? Should we carry
Yes,
on?
ma'am.
Any other question? Okay. Thank you. Then we talk about another case. So sorry, I've already given you guys the answer. So this is the last one. 37-year-old female. Pardon? Yeah, a 37-year-old female. Many year history of mid-thoracic to neck pain, recently more persistent pain around the neck and between the shoulder blades, intermittent lower back and hip pain. Symptoms improve with yoga movement. This is a straightforward one. No radiation into the upper limbs, no upper limb numbness, weakness, or
Through
paresthesia.
arthritis.
Yeah, it is a straightforward one. What is the clinical pattern? Is spondyloarthropathy, axial spondyloarthritis. So what will you do? What is your imaging decision? Will you request for X-ray, or will you request for MRI, or will you request for something else? Any plan for this patient? Are you going to manage her as a physio, or are you going to escalate? What will you do?
Hello.
Yes, sir.
Manage transfusion.
So, the patient is presenting with, like you said, almost textbook spondyloarthropathy.
Yes.
Spondyloarthritis. However, he also reports recent blood vision.
Yes.
Definitely, I will manage her and also manage her for the arthritis and refer to an ophthalmologist.
Okay.
However, the imaging, I don't see any reason to send for any imaging, especially not urgent, definitely. I'll treat and see how she responds to my treatment as a therapist. Then If there is no response, then that's when maybe imaging may come in. However, I'll definitely refer her to an ophthalmologist for the eye issue.
Good. Good. Any other input? And when you say, sorry, sir, just one question for you. When you say you're going to treat her as a physiotherapist, what will your, how will you manage her? Like, how will you treat her? What will be your goal? What are you after? What do you want to treat per se?
So, basically, I'm going to ask for some of her history. If she has history of overhead function, or if she has a history of carrying heavy lifting, because usually either prolonged sitting are usually the causes of uh, mid thoracic neck pain. So posture or prolonged sitting, heavy lifting, I'm going to advise her to avoid that. Then thoracic mobilizations, active thoracic mobilization will be my exercise to give, and also maybe in fact, she's actually a sitter. Look at it. She said intermittent low back and hip pain, mid thoracic neck pain. These are key factors to make you know that this person is a long sits for long.
Yeah.
So definitely
Lifestyle modification.
lifestyle modification. Thank you. Lifestyle modification, work modification, and also exercise.
History of CS, if she has any.
Yes. So when you're stratifying her, history, oh, sorry, you said history of what?
C-section.
C-section. Why would you check for that, please? Sorry.
Because some C-section female who are some C-section female usually present with neck pain, some of them, and they also present with lower back pain due to the anesthesia.
Yeah.
And that's why I said maybe in the history you have to ask, since she's at childbearing age, that's 7 years old. So you can also rule out that one.
So if she's got pain, like if she's got a positive history of cesarean section, that might also be contributing to the mid-thoracic lower back pain. So will you now, which pattern are you going to classify it? Are you going to classify it as mechanical back pain, like how will you classify that back pain? Like, yeah? So assuming, yeah, it's a good one. It's a good one. Assuming we screen out and it's not good. It's a good one, honestly. Assuming we screen out and she's not spondyloarthritis. So, and she have a history of C-section, then what will you say is the diagnosis like? What will you conclude? Because honestly, this is my first time of like hearing. Yeah, I know that the people, individuals, like patients who come in with back pain after childbirth, and then you do get. But in this type of condition, how will you note it? Like, what will you check? What any other thing that any input, like maybe educate us on what to do when we say
Yes.
it was like that. I would want you to educate us on what to do. What is it that we need to do, like as physio? It's a learning session for all of us.
Yes.
So
She lifestyle modifications comes in,
yeah.
and she needs to like be careful with the way she sits, like the way she carry weights to, and the way she move on with her activity.
I'm sorry. I'm just checking for something. I can't hear you. Hello? I can't hear anyone. Can anyone hear me, please?
Hello?
Yes, we can hear you.
Yes, I can hear you.
Hello?
Yes. Can you hear me?
Yes, I can hear you.
Okay, so it went up a bit. I'm like, so you are saying you are educating us on what to do for this patient and what we will label her. What are we going to say is the cause of her back
No,
pain?
maybe it's mechanical.
Mechanical back pain. So we label it as mechanical back pain.
Yes.
Okay, thank you. Any other input?
Yes, thank you very much, Ma. This case, a case of 37-year-old female, and the history of, under the past medical history,
Yes.
ulcerative colitis can refer pain to mid-thoracic and then around the neck. So certainly, I will educate this individual.
Yeah.
I will first find out how well is managing the ulcerative colitis. So I will advise her to ensure that she manages it well in terms of some food, avoiding spicy food, and then always ensure that the individual takes water. So as regards mid-thoracic, there is no issue with that because referred pain from colitis will suddenly make her develop mid-thoracic and pain around the neck. So that's how I'm going to handle that. So the likely pattern of this is mechanical pain, possibly due to, overuse. I would like to know the occupation of this individual, if it's a kind of occupation that requires her to sit for too long a time,
Yes.
or if she engages in lifting activity long standing. So I will advise that on that. Radiological investigation might not be necessary in this case. So in as much as back care education is given, that can handle that. Then looking at another concern in family history, the likelihood of these individuals to also have rheumatoid arthritis is also there.
Yeah.
So if most likely I will refer after giving back education and then postural education and then some other self-management in terms of pain which is not recurrent, which is intermittent and low back, then I might advise the individual to consult with rheumatologist. So that's my contribution. Thank you.
Thank you. So can we move forward then? Haven't heard from, or does someone, I think Dr. Olaleka want to say something. Her hand has been raised since. Yes? Or has she spoken already? Okay, let's just move on. So with this patient, what is it that we are looking for? First of all, before I move to the next slide, I want us to remember the manifestation of spondyloarthropathy. We all know it's an umbrella term for inflammatory diseases, but then it's got like three manifestation: the peripheral manifestation, extra articular manifestation, and then we've got the axial manifestation, and all of this somehow overlap. So sometimes you find out that someone is having that one, and then let's say you're having peripheral manifestation. Under the peripheral manifestation, I think we have the arthritis, we've got dactylitis, and enthesitis. So let's say we've got arthritis, which is mostly oligo, which is, let's say, affecting the knee. And then that is one manifestation from peripheral arthritis, right? And then in another manifestation here in the extra articular manifestation, we've got the psoriatic symptom as well. So we say an individual has got psoriatic arthritis. So all in all, they can somehow overlap. So a patient that is coming with ulcerative colitis, which is more a manifestation of extracellular, extra-articular manifestation, and at the same time she's complaining of like blurry vision. I think that should also make us put that together as also into the still extra articular manifestation. This is shooting coming up. And then when we look at her age as well, 37 years old female, that age, that age, that is like less than 40, 45, then it's also a key thing for us to note there. And then she's also got a family history of seronegative arthritis, her mother and her sister. I think this should be more than enough pattern for us to like screen her more for axial spondyloarthropathy. And then she's having pain that is getting better with yoga movement, which is okay. Another pattern of spondyloarthritis, axial spondyloarthritis, is alternating pain in the gluteal region or in the buttock, which this patient has also reported. But objectively, we've screened everything. Neurological findings are okay. So yeah, I don't think it's anything that has to do with radicular symptoms, sciatica, or no, radiculopathy. And surely I'm not going to fit her in for mechanical back pain because of what like the presentation. So this gets us to just discuss the reasoning point, like I've just mentioned, all those concern that is raised, the young age and the stuff, but then the likely approach with the clinical pattern, then I'm looking into maybe ruling out like considering blood tests. We can arrange blood tests in the within the primary care, but what we can arrange is CRP, ESR, HLA-B27. That one has to do with the secondary care, and it's got to do with like the rheumatology. Sometimes the rheumatology will not accept a referral if we are not giving them full reason, like if we are not giving them reason enough that we believe that this patient have got rheumatoid axial spondyloarthritis. So definitely not only the clinical pattern needs to be looked into, then we also need to look into other things like the blood. We can arrange CRP, ESR, like I said, but imaging. What imaging are we thinking? If we're thinking X-ray, some might be non-radiographic, some might be radiographic. Again, if I request X-ray, it might show nothing. But then clinically, the pattern is fitting in for me as this axial spondyloarthritis. So what do you think I should refer best? I think I will refer best for MRI. And of course, it's not going to be the normal MRI. I'm going to indicate in my referral. For this patient, I am thinking, oh, my impression is axial spondyloarthritis. So I want STI MRI, STI T1 MRI, the whole spine and the sacroiliac joint should not be excluded. So if there is anything, that will be cleared with the MRI. So again, that like a kind of I'm cleared. It can be radiographic, non-radiographic, but then with MRI, definitely I'm going to see something if I'm thinking this patient is axial spondyloarthritis. Someone mentioned about the eye issue, her blood vision. I think that is something for me to look more into. Physically, I can see the patient if she's got a red eye. I will ask since when the redness started. I can check any photophobia, any pain in the eye. Is it unilateral or bilateral? Any previous episode? I will just have to screen for that eye symptom, only that eye, because if I just treat her as like with the back pain only, and then she's got that one, if my concern is okay, she's got axial spondyloarthritis, I will refer her for this, for that, but then I left that eye untreated, she might not really take it serious because she didn't know that this is another manifestation for spondyloarthropathy. Like this is another symptom for me that I need to look into, and then it can get worse and then affect her eyesight. So definitely I need to look into it as the first contact. That's why I am the first contact. So I'm not only screening for MSK, I'm also screening for other medical conditions that the patient might present with and can cause potential danger, like can be potentially dangerous to the health of that individual. So I will consider possible uveitis, and then I will arrange for another urgent ophthalmology assessment. Yes, urgent, because if left untreated, then we're talking about the eyesight, and then we're talking about no eyesight. And then, like, yes, so it's not going to be me only thinking, oh, I can give her some stretches. Yes, with with the referral, with the blood test before they come back, obviously it's not going to be urgent. I have done the best I can with the eye, which is more urgent for me at that moment, refer her for ophthalmology assessment. Obviously, it might have to follow through the GP, but then I have done what I need to do. But how do I manage what she presented with to me as the MSK physio, like FCP physio? Yes, like someone has said, give her some exercises and then activity modification. And we can also simple NSAIDs. Sometimes it gets better with simple NSAID, ibuprofen tablet, ibuprofen gel, because she is having ulcerative colitis, so it might affect her GI, like her stomach. So I'm not going to say, okay, ibuprofen tablet. I can prescribe the gel and then maybe paracetamol to ease the movement, the pain, and then carry on with some gentle exercises. Obviously, she's good in yoga. Look into how she's doing it, see if there's anything that I can add, plus or minus. And then when the blood test and the MRI result is back, and then I can now think of rheumatology referral. She's been having it for quite a long time now, so rheumatology, it's not something that they will just like discharge her today, tomorrow. So she's going to be with them, obviously, for the management. So yeah, that's how to manage this patient somehow from the FCP perspective. So we move.
Thank you.
Yeah, that's the last one. I think that's we done for the day. So we just look into yeah, that's it. Mechanical, the take home messages, like mechanical low back pain is common, but then serious and inflammatory pattern must be actively screened out. We should always remember, because patient have got like ulcerative colitis, we say, okay, just manage it that way, that way. Don't take too much of spicy things. Don't take this, don't take that. They might need another input from rheumatology. Just screen out for anything that might just prompt you to refer them for rheumatology assessment. Rheumatology, let the rheumatology know your concern, and then that is a plus for you as a physio. Like, I went to see the physio, but then the physio did not only manage my back pain, he or she also managed something I never knew I had. So that's a plus plus for us. So radicular pain and radiculopathy are not the same. Yes, that's it. Objective neurological deficit change the decision making. So with radicular pain, we can manage, just a trek in lifestyle modification and then activity modification and a bit of paracetamol, ibuprofen tab, ibuprofen gel, neurogesic, massage, heat, and stuff like that. Exercises that can help with the radicular pain, but with the radiculopathy, that definitely needs something, like we need to really look into it. If it's something that can be managed conservatively, or if it is progressively getting worse, then what to do? Either imaging or escalation to the spinal team or the appropriate referral pathway. Again, axial spondyloarthritis is a pattern diagnosis supported by blood. So blood alone, because patient come in with back pain and then we did our assessment, oh, it is axial spondyloarthritis, let me refer for blood. No, we have to correlate the clinical pattern with the blood and then with also the imaging, and we should know the type of imaging that we are requesting, because we might like just request right MRI to screen to rule in or out axial spondyloarthritis, and then the MRI people, I don't know, some might know that this is the one they are supposed to do, and others might not know. But once you indicate the type of MRI you want, I think that will save the patient also some change, some money. So yeah. And risk stratification, guide support intensity. It does not automatically justify imaging. So because someone is high risk, that does not mean I should send him for or her for MRI or for any imaging. I still have to look into all those clinical pattern, neurologic symptoms, if they fit in the imaging and onward referral, or they fit more in with close monitoring, MSK, and pain, like liaison with the GP for or the pain clinic to optimize their pain, maybe neuropathic pain, if non-steroidal anti-inflammatory is not helping, and other physio, then we need to optimize neuropathic pain. Neuropathic pain, somehow it's been somehow debated here, but still some patient cannot do amitriptyline and nortriptyline dependent. But again, it says that if the patient is having pain, it's a chronic pain, then amitriptyline will not do anything. But then in acute pain, then you can use amitriptyline, and then you can gradually wean the patient and then carry on with physio management. So it's not something that patient will be on for life or like for a long period of time. Just know how to use those things. And definitely as physios, we're not doing the work of the GPs, we're not doing the work of anybody. We just like communicating among ourselves. This is what I think. What do you think? I think I'm thinking more, I want more this for my patient, pain optimization as a GP or as a pharmacist. How do we help? Like, what should we do? And then the pharmacy would chip in, and then the pharmacy would say it. So at the end of the day, it's a kind of a family. It's not, and to be honest, it makes works easy for everyone. Like, I don't have to start thinking I have to do this, I have to do that. No, once I see this is what the patient need, I just refer to that person, and that person will definitely look into whatever I've sent to him and knows what, if there is any concern, they get back to me, and that's it. We sort it out. At the end of the day, patient is happy, and that is it. That's what our aim is. Imaging should answer a clinical question and change the management, the urgency or the referral decision. So imaging should not be for reassurance. It should be because we want to escalate. It should be because we're thinking something serious is happening and we need to rule in or rule out so we can manage appropriately. And yeah, that's it. I think these are the selected references, and we've come, 2 hours. Thankfully. Thank you everyone for having me today. Any question?
Thank you.
Thank you. Any question for me?
Yep, yep, I do. Can I go on?
Hello.
Yes, anyone that wants to talk?
Okay, thank you for the lecture. I was going to ask a question, but I think you've answered it, but I'll ask it anyway in case there's something else you want to do. When you were doing the case study on the last one on axial SpA, I got kicked out because of the network. But I was confirm that, so the reason for imaging is to establish the diagnosis of axial SpA and escalate, right? That
Yes,
is
yes.
okay, all right. Then for start back, I'm familiar with start back, and when it comes to the people who will be stratified as high risk, I know it involves psychologically informed stuff. So would we need trainings on that? Because I know in school, like in undergrad, we do psychology and stuff, but I don't think it's that kind of. I don't think they don't go through the models
Yeah.
for you know psychologically informed pain and all that. So what would your approach be in our setting? Would you have to involve something like referral to mental health and try to co-manage that with them, or What would the way forward be?
So I think it all depends on the local pathway as regard that one. I practiced in Nigeria before coming here, and I don't think we have that. So basically, we the physios are the psychologists, like we do that work, that cognitive behavioral therapy. Actually, some of us can like go for the course, have idea, and then still be able to chip in when managing, because here we've got a pain team. So you see, as FCP, when you screen and you think this patient is high risk and need further management, you refer either for pain review with the pain clinic. So in the pain clinic, we've got people that are specialized, they physios, I think. I'm not sure, to be honest. I'm not sure if they are purely physios, but they are. I know there are some physios working in the pain clinic, but I'm not sure if the cognitive behavioral therapy, those that are doing that cognitive behavioral therapy, if they are purely physios. They could be psychologists, they could be mental health specialists. So I think if we don't have such thing in Nigeria, if we don't have like such people like the mental health specialists, if it's something that we as physios can enroll in, have idea on how to manage pain more, I think there is a pain community or pain something. If I can still remember, there is something that has to do with pain, and it's like an association in Nigeria. So we can just like look into
Yes.
how we will, as physios, how we can also be there, and how to manage patient with such pain when we talk about cognitive behavioral therapy, when we talk about prescribing pain medication, because we have to be prescribers. We will not just prescribe just like that because we are physios. No, we have to also carry on the courses. At least that is how it is done here. But back home, to be honest, I don't know. So maybe our seniors, our elders will be able to shed more light on that pathway if we really need patient like input from mental health specialists, psychologists, or any team that does that cognitive behavioral therapy. Because we are physios, like we are not master of all, jack of none. So I think that's what I would just say. Sorry, I don't have much to say regarding that. Any other question? And let's look into the chat to see if we've got any. Yeah, so someone, Ridwan Abdul Fattah said, International Association for Study of Pain Physios are plenty in the group. So I think it's something worth looking into. See how they're doing their thing and see how we can be more beneficial. Any other questions? Society for Study of Pain. Okay. Any
Yes,
questions? Questions?
no, it's not more of a question.
Okay.
It's more of shedding light on the pain community.
Okay,
Because
sir.
happens to be that I work in UITH in Lorin. Some
Okay.
hospitals, they
Mm.
have a pain and palliative unit. And those units is a team that
Mm.
encompasses medical doctors, surgeons, physiotherapists, and all that.
Mm.
So any patient, they do all around together. Any patients with such pain, they work as a team. The medical team, they use all what they say, the who analgesic ladder to treat using medication, while the physiotherapist is the normal conservative method of treating pain. So that's how it works. Some hospitals in Nigeria, tissue hospitals, they have their units, and it's a team actually. Happens to be part of the team UITH, and it's working well.
So I think at the end of the day, it's about communication between the team, like the multidisciplinary team. We have to make ourselves known to them. And this is
Yes.
like our patient we can also send some of our patient, and this is what we want, like what we want you to do for us when the patient come. So it's a kind of Sorry, I don't know how to say it.
Thank you. Well
The
done.
other thing, the facilitator. Are we good to go? Are we good to end the
Okay,
session?
sorry, one more question.
Yes. One more question,
Can I
sir.
go?
Yes, sir.
Okay. Yes. So for low risk on with the start back, I know it's usually like self-management strategies and all. And I have when I read up on papers where they say that the thing is I have never seen like those strategies really outlined. I know they talk about like giving booklet, and I have tried so hard to find maybe like the PDFs of some of those documents for the self strategies. I mean, I have an idea on certain things, just try to get them, okay, how you can manage flare ups, what you can do. But I'm still really searching for something very structured. So I don't know if you have access to that and if you could share something.
So if I got you correctly, you're looking for, let's say, like a guideline on self-management,
Yes.
something like that.
Yes.
To be honest, I've not come across such as well, but like logical thinking, if you think of it, what might be the cause of this person's non-specific back pain might be different from the other. So it is you who does the assessment, obviously might have find out from your assessment what causes more the flare up, and you will be able to address it. Does that make sense? Like there's no guideline, but as clinicians, I think we are open to, our clinical reasoning and clinical decision making should go hand in hand with what the patient is presenting with. Maybe me and you, or you should lead us on a research regarding that, and then we can put something down. Or what do you say? If we're looking for and we still can't find, then we should come up with something. Yes? Okay. Facilitator, am I good to go?
Yes, ma.
All right
Yeah,
then.
what to do?
Thank you everyone for having me today, and hope to see you next week.
Thank you so much, ma. We really appreciate.
Thank you. And yes, please, if there is anything you want me to improve on, anything you feel I did not say or I need to do, anything at all, any feedback, just drop it on the WhatsApp chat and then I'll pick it up and then I'll work on that. We're always working on ourselves anyway. Thank you.
Okay, bye-bye. Thank you.